If you look at it from the perspective of a pediatric neurologist, my job is to make sure that the paperwork's signed and all the orders are checked off. But if you weren't there to save the patient, the pediatric neurologist is not going to make the difference. I'd like to say that I have no disclosures and no conflicts. And I'm going to have 4 objectives for today's talk. And I'm going to go through them fairly quickly. And I can use a pointer off the center slide. But for those of you, I'll try to talk through on the ones that are using the side slide. I'm going to go through some epidemiologic data to make the argument that strokes in a certain age range in children are not that uncommon. And then I'm going to go through some basic background, and I think a lot of you are going to be familiar with this material that talks about how you recognize different stroke types and what are the difference in children as opposed to adults. I believe all of you have a Central Ohio Trauma System stroke card, and one of the questions is whether this card could be applicable to children, and the bottom line is I think you can use it with some limitations. And I'll talk a little bit about initial stabilization both in the field and when the patient comes into the hospital, and I think most of you will be very familiar with this material. And I like to talk about from a very, very general background. Think of the circulation to the brain as like house plumbing, because I think everybody can relate to that. You have a high pressure system that supplies your flow. You have a low pressure system that essentially drains. So you can have stoppages in your high pressure system, either from a thrombus or from an embolism. You can also have stoppages in your drainage system. And if you have stoppages in your drainage system, sometimes it doesn't cause any problems, but sometimes you can have an overflow. And any time that you have a rupture in the system where it breaks, you can have bleeding into the brain. So if you understand home plumbing, you'll essentially understand stroke neurology. To go through this in a little bit more detail, and I'll use this for some of my background, the way the neurologist thinks is that you have 2 forms of circulation. You have your carotids, which circulate and supply the front part of your brain, and then you have the vertebral arteries that go and supply the back part of the brain. So we talk about anterior and posterior circulation strokes. And then you've got the different sides of the brain. And what this cartoon here demonstrates is that the anterior circulation provides supply to the middle cerebral artery and the anterior cerebral artery on one side of the brain. And then you have the corresponding supply in the back, while the posterior circulation supplies the brainstem and the cerebellum and back parts of the brain through the posterior cerebral arteries. But these are the big guys. These are the big plumbing lines that you have in the brain. And this cartoon on the right-hand side is to remind you that it's not just the big circulation, but you have these penetrating vessels that go into the brain, the smaller caliber arteries that sometimes we don't see on X-ray studies. I talked about a low-pressure system, and that's obviously the veins. And this diagram on the left-hand side demonstrates the very fine, very small caliber network of the veins that drain into the larger vein collections. And I'm going to use the term sinuses. Now, we all think about sinuses when we get congestion of the sinuses, but when a neurologist talks about sinuses, these are the big, large veins that drain through the top, through the center, and then drain to the side and eventually go into the jugular vein. So you can have occlusion of a sinus, or our term is a sinovenous thrombosis, that's essentially a venous occlusion. So how often do strokes occur in children? And I'm going to talk first about ischemic strokes, and then I'm going to talk about hemorrhagic strokes. And ischemic strokes are where you have blockage of your arteries and your veins. And the argument that I'm going to make is that stroke is not all that uncommon, depending upon what age range you look at. If you look at adults, older adults, an annual incidence for stroke is about 1 to 2 per 1,000 per adult. If you look at newborns who have arterial ischemic stroke, that's about 1 to 2 per 4,000 births. So when you're looking at very young children, the incidence of stroke actually begins to approach that of adult stroke. So it's not that uncommon. You just don't think of it from that particular way. Clearly, after you get out of the neonatal period, stroke is much less common, and the best estimates are maybe 2 to 4 out of 100,000 per year. So clearly, arterial ischemic stroke in children is uncommon, and venous or sinus thrombosis is even less common. Best estimates are maybe 2/3 of a case out of 100,000, so distinctly less common. And that creates a problem in terms of thinking about, does a child have a stroke or not, because it's just not common in a certain age group, whereas in adults, you'd think of it as one of your leading diagnoses. This is a very busy slide, and I basically want you to look at the center part of the table. And what these are estimates of hemorrhagic stroke. And the bottom line is that if you use administrative databases, the best estimates are probably the frequency of bleeding or hemorrhagic strokes is about the same as arterial ischemic strokes when you're talking about children. There's some variation, but I would say that hemorrhagic stroke is probably about as common, and it's something you don't really think about. People haven't paid attention to. Okay, so frequency, depending on the age range, not that uncommon. So what makes you think about a stroke? And I'm going to go through some very, very general principles as far as background. And I'm first going to talk about arterial circulation, arterial stroke, and the top part of the slide is going to talk about the symptoms with anterior circulation, and then I'll delve into posterior circulation. And remember, the left side of the brain controls the right side of the body, and that's always very confusing. But if you have a stroke of the left side of the brain, you may or may not, depending upon the location, have weakness and sensory loss in the right side face, arm, and leg, the sensory motor system. And then if you've affected the left side of the brain, you may lose speech. And depending upon how extensive the stroke is, you may lose vision in the opposite side. But it also depends upon location and size. You can have a small stroke sitting in the front part of the brain where it doesn't pick up anything. So somebody can have a silent stroke and there's no external sign for you to be able to identify that. So these are anterior circulation strokes. How are they different from posterior circulation strokes? The posterior circulation serves the brainstem, the cerebellum, and the back part of the brain. And here's sort of a different way to look at it. And because the brainstem is essentially a communication pathway that's so congested or so compact, it's hard to damage something without multiple systems getting involved. But the predominant feature that you would expect is either facial weakness or disconjugate vision or dizziness or nausea that are really disproportionate to the rest of the clinical examination. So that's really the striking feature. There may be losses, inability to speak clearly or hoarseness, but there isn't the inability to speak per se. And then the other feature is that you oftentimes have crossing. So you have right face weakness, but you have left arm and leg weakness. And so how do you have that type of crossing? You can get it in the brainstem. So the point is that these are the same types of patterns that you see with strokes in adults. There's no major difference with them if they fit this general pattern. Venous stroke is a little bit more tricky. I would say that the neurological deficits are going to be very similar to arterial strokes, but the difference is that, go back to your plumbing example. If you plug up your high pressure supply, then you don't get any circulation whatsoever. If you plug up the drain, you still have supply going in. And then if the plug isn't too bad, you may actually not have any damage whatsoever. If the plug is big enough, then you may have loss of circulation, or it may just spill over and you've got bleeding into the brain. So partly it depends upon location, partly it depends upon the severity, but you can have a venous plug and have no symptoms whatsoever, and that holds true in terms of kids as well as adults. And you can even have a venous thrombosis if in this particular individual, when you don't see that major vein up on the top because it's all completely plugged up, but she didn't have any stroke. She just had severe headache and brain swelling. Hemorrhagic stroke is going to be much more dramatically different. But the presentation and your ability to pick it up does depend upon kids. We looked at some 85 kids in children's who had developed bleeding within the brain. And there was a relative cutoff based upon whether the kids could be able to report their symptoms. And what I mean by that is that a little kid had relatively nonspecific findings. they would have a sudden onset of an alteration of consciousness. They may not go completely comatose, but they're clearly not at their baseline level of function. They may have vomiting, they may have convulsions, and these are really fairly nonspecific symptoms, but those were how the little children presented. Once you got older than 6 years old, you could be able to tell people you got a headache, and that was the real differentiating features. Older children with a hemorrhage within the brain had sudden onset of headache. Then they also had altered mental status, nausea and vomiting, convulsions, and some of them had neurological deficits. But in that regard, that presentation was similar to adults. Subarachnoid hemorrhage, we don't see very many in terms of children. That's where you have bleeding from an aneurysm that covers the surface of the brain, and that's going to be the sudden onset of a severe headache, alteration of consciousness, vomiting, and there may be a very stiff neck without a fever. And in those individuals, that presentation in children is the same as in adults. So if I'm going through this list and saying it's the same in adults, same as adults, same as adults, what's the difference? Well, the difference is that there's some features that crop up in kids that you don't typically see in adults. And a key feature is strokes in children may present with seizures, and that's very heavily skewed toward the very young children. Neonates, about 4 out of 5 kids will actually present with seizures, and that's the way you know that there's something going on. And when you deal with younger children, particularly below age 5, seizures tend to occur. If you look on your stroke cards or other guidelines, they'll make a comment that seizures in older adults has to make you think that there's something else going on, whereas in kids, that actually still keeps it on the radar screen. The difficulty further is in the neonates, in the young ones below from birth to 1 month. Their findings are oftentimes nonspecific, and so when a couple studies looked at newborns with arterial ischemic stroke or sinovenous thrombosis, what they found is that most of the features are nonspecific. Seizures, abnormal tone, which means a floppy kid, impaired consciousness, and in the majority of cases, these were the prominent findings. The focal signs that would make you think of stroke actually occurred in the minority of cases, and these tended to be one side was not operating properly. So I'd say that it's much more of a tricky diagnosis in young infants than it is in older children. But the other feature that makes the diagnosis difficult is remember that frequency of 2 to 4 per 100,000. Stroke in children, arterial ischemic stroke, isn't very common, whereas epilepsy, complicated migraine, intoxications are going to be far more common. So when somebody comes in with the acute onset of alteration of consciousness, and maybe they don't use one side of the body so well, you have to look at the common things first, epilepsy, intoxications, and migraines, rather than leap to the diagnosis of stroke as your leading possibility. If you have an 80-year-old who comes in with an alteration of consciousness and they don't move their left side of the body so well, you're not going to waste your time thinking about the other diagnoses. So I think that that's the real big hooker. And I'm going to give some clinical vignettes, 5 clinical vignettes, and this is a good chance for you to just sort of listen to some case histories and put in your own mind, is this a stroke or is this not a stroke? So let me give you vignette number 1. Vignette number 1 was a 16-year-old who was previously healthy. And then one day in school, she just told the school teachers she didn't feel well, and boom, she goes down. She's got an altered level of consciousness. She's poorly responsive to questioning. In fact, she doesn't answer questions. And notably, she doesn't move the right side of her body. They take her to a local emergency room. She's got a CT scan. And for those, this doesn't show up so well on the distant, but if you look on this side of the brain, it just doesn't seem as radiodense as it does on the other areas. So there's something going on that's localized there. Okay, so that's vignette number 1. And mentally, I want you guys to ask yourself the question, you think it's a stroke, yes or no? And I'll come back to this. Vignette number 2, 15-year-old, previously healthy kid, playing basketball with his friends, and then suddenly he just couldn't use his right arm and leg. And at the same time, he couldn't speak clearly, so his friends see that there's something wrong, so they take him to his mom, And when mom asks him questions, he can't be able to answer the questions appropriately. So he gets whisked off to the local emergency room, and they run a CT scan, and the CT scan is normal. And so then they ship him down to Children's because there's something going on with this kid. About a month after that guy shows up, we have another 16-year-old who's previously healthy. Now, his history is a little bit different. He had some seizures 3 days prior to presentation, got brought into the emergency room, got checked out, couldn't find anything, said follow up with a neurologist. So he's in the pipeline to be seen. But then suddenly, he develops an altered level of consciousness. He can't answer questions. He can't move that right arm, he can't move his right leg, and he can't move his right face. So he gets CT scanned, that's normal, and he gets shipped down to us also. And remember, this guy came in about a month after the first one, so there's something funny going on there. Vignette number 4. This is a 2-day-old, previously uncomplicated term pregnancy, normal birth weight, goes home with mom, and then parents report 2 days after birth that he has these repeated episodes. His back arches out, his arms go off to one side, and they shake like this, and his eyes roll up into his head. And so there's no family history of epilepsy or other seizure disorders, so there's something going on with this kid, and he gets admitted. And the last vignette, there's a 14-year-old who is substantially obese. She's got sleep apnea, she's got asthma, but she's had increasingly severe headaches for about 12 days. And these are bad headaches. She's got nausea, she's got vomiting, she's light sensitive, she's sensitive to sound. And in addition to that, she sees, everything that she sees is blurring, it's just not clear. And she tried over-the-counter medications, they didn't make things better. And the pain was severe enough that it would actually wake her up from the middle of sleep. So she comes in, she has a CT scan, that's normal. But then they find that when they do a spinal tap, that her opening pressure is, if the normal opening pressure is 25 centimeters, she's like 38 centimeters. So she's way, way elevated above where she should be. Okay, so you got 5 vignettes, and let's walk through and see what let's just do a show of hands. This is going to be real simple. To remind you, the girl who collapsed and had the abnormal CT, how many in the audience think that this patient had a stroke? Okay, makes a lot of sense. She's got something in her brain, and I would think that that's a reasonable estimate. That's what I thought when I saw her. She had a brain abscess. She had a pig tapeworm that had migrated and caused that abnormality. And so she clearly didn't have a stroke. She had a brain infection and responded to appropriate treatment of the abscess. Okay, the basketball player. Okay, just because the first one's not a stroke doesn't mean that this one's not a stroke. How many folks out there think that this guy had a stroke, the basketball player? Okay, the hands are sort of reluctant, but okay, go for it. This guy had a blood clot in his middle cerebral artery, and we just, I talk about this kid because we got him just within the window to give him that intravenous clot buster, and he literally improved as the medication was infusing. And if we delayed a little bit longer, he probably wouldn't have responded and been left unable to talk. Okay, next guy. This next one's a month after the first one. 16-month-old, sudden onset of right-sided weakness, and he couldn't talk. How many of you guys think that this one's a stroke? The hands are getting less and less. I guess the coffee's wearing off. Okay. This guy turned out to have mosquito-borne lacrosse encephalitis. And he happened to have a very focal presentation, but he would not be a candidate for a clot buster because he had an infection and he didn't have anything related to a stroke. The 2-day-old, okay? 2-day-old, new onset of seizures. I see like 1 or 2 hands. Okay, so nobody thinks that this kid had a stroke, okay? Right? Right? Okay, so this kid had a huge right hemisphere infarction, and he has, we're following him, but he's had an extensive stroke of the right hemisphere of the brain, and we'll have to see how he does. Okay, last. The 14-day-old girl with a severe headache, and it doesn't get better, and she has a high opening pressure. And I see some brave souls putting their hands up, but the hands are, okay, the hands are coming up a little bit. But it's always the same guy in the back. She had a huge clot that just stopped up the vein from the top part of the brain and actually plugged up the vein draining off to the side. But she didn't have a stroke, but she had a thrombosis of the vein, and she would still be considered within the stroke category in pediatric neurology. So I use those vignettes to illustrate that the problem is that there's other stuff that occurs more frequently. There are cases that show up with stroke, and you have to think about it, but you also have to think about the other possibilities. And this table is from a study that was performed in a major children's hospital in Philadelphia. And they have a stroke service, and they just simply kept a logbook of all the cases that they had. They had 140 times that they were consulted for a possible stroke. And of the cases that they had that had possible stroke, 11 of them had conditions that were not even neurological. 19 of them had neurological conditions that were a variety of different causes. And so, again, there are uncommon neurological things that can look like stroke that aren't. And that's where you have to be able to sort of sort them through. So the dilemma. Now, the question is, can you use a card like the COTS card to help try to be able to at least make you think about the diagnosis? And the key feature in the COTS card is decreased level of consciousness, slurring speech, facial weakness, arm weakness. And these was actually developed from stroke cards, if you will, developed in Los Angeles and Cincinnati. And I think it makes a reasonable estimation. So does it work? And the answer is kind of. And here's an illustration. There's nobody that's actually tested the COTS card, but there was a retrospective study from Australia where they looked at kids that had presented in Melbourne Children's Hospital, and they looked at two other stroke tools. One's called FAST, facial weakness, arm weakness, speech impairment, and very similar to COTS in structure. Rosier is an emergency room doc key, and it's a little bit different. So they looked at they looked at 47 kids, and they found out that FAST could actually, for a kid who is known to have a stroke, FAST was positive in about 76% of the cases. In those same 47 kids who had stroke, Rosier was positive in 81% of the kids. So the point, the point of this is that these cards are helpful, but they tend to miss stroke because children can have a variety of different presentations, and the little ones are actually fairly difficult to make a diagnosis. So you can use a card as kind of like a reminder. Say, you put it up and say, geez, I need to think about stroke as a possibility. Here is another feature that sort of brings this to home. This is a voluntary registry of cases of children who have had arterial ischemic stroke that is submitted to a large database. And what these bars are, on the left-hand side, the blue and the beige bar represent frequency of stroke in children who are between birth to 1 year. And if you just add up the numbers, about 40% of the strokes in this registry were for little children. So one of the features that we have to deal with in pediatric neurology is the more common occurrences are actually in the neonates. They get distinctly less frequent as you get older, and roughly 60% above age 1 to 5. But I would argue that for the kids that are 6, 10, 15 years old, these cards are probably very good clues, at least to make you think about the diagnosis. The question is, for the age 1 to 5, sometimes you have to make some judgments. So, again, in the field, what would make you think about a stroke? First of all, you just got to have a high level of suspicion. And then the key feature that you're looking for is that you're looking for a sudden onset of neurological deficits. And the difficulty is that the deficits may be diffuse, altered level of consciousness, vomiting, dizziness, or they may be fairly focal. One side doesn't work and the other side does. But what you're really looking for is typically a catastrophic onset, although sometimes the catastrophic onset may appear as more of a very rapid staircase deterioration. So I think in that setting, when you use the COTS card, you can at least use it as a reminder, as a clue. And I think the real challenge for emergency room staff and also for EMTs is that you've got the patient, you then trundle them in, and then you're talking to a doc, and the doc's looking at you and say, well, you know, kids don't have strokes. And I would argue that they do, they just don't have them very often. And so I guess the real challenge is that, number one, you've got to make your concern known. Yeah, the doc's kind of boneheaded, but at least I'm thinking about stroke for the following reasons. Sudden onset of a neurological deficit, I'm looking at this pattern, and you guys have to think about that. And true, they have to think about the other things, but at least you can alert the doc that you have to worry about stroke as a possibility. Okay, now a little bit about initial stabilization, and I think this is going to be old hat to many of you, but let me just make sure I go over the basics. The ABCs in the field are critical for stroke recovery. Number one, you want to protect your airway, and the unique difficulty with stroke in children as it is with adults is that sometimes when you have facial weakness, you also have airway protection weakness, and so these individuals are at risk for airway occlusion, aspiration, so make sure you're protecting the airway, make sure you're maintaining adequate oxygenation. The other feature with stroke is, remember, this is a plumbing problem. If you have poor perfusion to the brain and you've got a plug, then you're not doing the patient any benefit. So you want to maintain the pressure at least in a normal range for that age range. And if you've got somebody that's clinically hypoperfusing or dehydrated, you want to fill up the tank with normal saline. Now, they always say in stroke, don't overload the patient. That's correct. And really, this is a Goldilocks phenomenon. You want the patient not too wet, not too dry, but just right. And you use normal saline because hypotonic fluids, low sodium fluids, tend to contribute to brain edema, whereas normal saline is going to do that somewhat less so. And if you had a choice, if you got a kid that's maybe a wee bit hypertensive, just leave them alone, because maybe that hypertension is helping promote some of the circulation, and you can let the ICU worry about the details afterwards. And then avoid hyperthermia. Okay? So that's for the field. What happens if the patient comes into the emergency room? What actually happens at that stage? The challenge for the docs at that stage are trying to figure out, does the patient have a diagnosis? If they do of stroke, if they do have a stroke, is it a thrombotic stroke or is it a hemorrhagic stroke? And then you've got to work up the various causes. And you've got to work up the various causes for two different levels. Number one, you want to find out, is there something that could immediately recur and cause an additional stroke within the next few days? And then, is there anything that you need to be treating the patient for to try to avoid worsening? These are images that are, I think because of time, I'm going to really cut this short and just say what's really helped us in terms of diagnosis has been contemporary imaging. CT scan on the left-hand side is very useful because it's readily available. If you've got a hemorrhage like you do in this very left-hand panel, it picks it up right away. The problem with ischemic stroke, which you see in the second panel from the left, is that sometimes it's not very obvious. And if you've got a good set of eyes, you know what to look for. But in a very early ischemic stroke, you may not see anything. The third and the fourth panel really represent MRI scans. And the MRI scans are very, very useful because in stroke, they become abnormal within 4 to 5 hours, actually within 60 minutes of onset. The problem is that MRI scan is not always readily available, particularly in the smaller hospitals. This is a laundry list, and the laundry list is to illustrate that once you've established that the patient has a stroke, there's this laundry list that you have to work your way through, and that's why it gets to the evaluations can be fairly extensive. But once the patient comes into the hospital, basically we continue what you do in the field, and that's looking at the ABCs. Maintaining airway protection, oxygenation, maintaining cerebral perfusion, trying to avoid hyperthermia. So you essentially set the ball rolling when you see the patient initially, and we simply continue that at the ICU level. Are there specific treatments? Because I talked about a clot buster in that one kid. For most pediatric stroke, we oftentimes see them late, so most of the treatments are supportive. If you have something like sickle cell disease and the individual has a clot or a plug based on sickle cells, you can transfuse them and do an exchange transfusion, but that's the only specific treatment. What about clot busters, thrombolysis? And this panel is going to be very, very busy, but what I'm going to point out is looking at what this is a study that was performed in the Canadian system. And what they looked at is when did a child develop a symptom, when did they get into the medical system, When did somebody start talking about hospitalizing the patient, doing scanning, and make the diagnosis for a stroke? And it's quite striking. Most parents recognize that there's something wrong going on with their kid. So the kid gets into medical care within an hour of onset, and oftentimes within less than 2 hours, the kid's actually at a hospital. The problem is that oftentimes people don't come up with a diagnosis or don't think about the diagnosis. And so in this system, the median time to scanning was 8 days after the original presentation. So if you're talking about clot busters are good at less than 4 hours, they're not even picking people up in the system. So there's clearly a recognition amongst physicians that we need to make the diagnosis and we need to recognize faster. But first of all, the first step is to get them into the system and then try to make the system work. And this is the real reason why TPA or the various clot busters are not widely used in children. You got to weed your way through the alternative diagnoses, and sometimes the children don't get recognized till late. There are some meds that we use to reduce the frequency, reduce early recurring ischemic stroke, but they all have their pros and cons because they can all increase bleeding. These are heparin, aspirin, and if you don't know why a kid has had a stroke when they've just come in and they got a thrombotic stroke, we may put them on these medications while we sort through the other possibilities and then try to take them off once we've figured out what's going on. But the other feature is that the kids have to be monitored for evolution. And what I mean by that is that if you have a lack of blood flow to the brain, you oftentimes have swelling of the brain, and this swelling can actually contribute to a lot of further damage. And that swelling oftentimes doesn't peak till 48, 72 hours after the original presentation. And this can be a severe problem with a very large stroke, or it can be a severe problem with a brainstem or a posterior cerebellar stroke, because the cerebellum is sitting trapped underneath a very tough membrane, and there's no room for that to swell. I'm going to move through and for the interest of time, sort of go through these fairly quickly. Intracerebral hemorrhage, you need to watch the patient for bleeding if the bleeding gets worse or if it causes hydrocephalus. And in some circumstances, you may have to do an emergency removal of the hemorrhage depending upon the patient's clinical picture. And for bleeding from an aneurysm, we don't see these very often in children, but you really should try to close off the aneurysm early so it doesn't re-bleed. And I've talked about brain swelling. And the reason for these three different panels is to illustrate. The kid on the very far left has a small stroke. That's going to swell, but it's not going to swell very much. So you can actually probably watch that kid on the floor and not put them in the intensive care unit. This kid has this huge stroke where he's not only knocked out one hemisphere, but he's picked off a little bit of the adjacent hemisphere. And that's somebody that's at very severe risk for severe swelling and needs to be watched very carefully. This kid over here on the right-hand side actually has bleeding in the back part of the brain. And he needs to be watched very closely because that bleeding, a clot back there or swelling of the brain can generate an increased pressure very rapidly, and the neurosurgeon may actually have to take off the back part of the brain as an emergency decompression. So I've gone through this material fairly quickly, but I think that you can see my point that strokes do occur in children. For older children, they're not that common, but within the neonatal period, they're actually they begin to approach the frequency of older adults. And the patterns for recognizing stroke are going to be very similar in older kids with the patterns that you see in adults. It's just that the younger kids are different, and seizures can occur in stroke more often in kids than they do in adults, but it tends to be in the younger kids. You can use the COTS card. I think it's useful as a reminder. Remember that it doesn't pick up everybody. It picked up about 74, the stroke cards in that Australian study picked up about 74 to 80% of the strokes, and therefore there's a certain false negative rate. So it's not, think of it as a reminder to make you think and to make you present to the ED physicians, but it's not the Bible. And then finally, I think that initial stabilization in the field, it's ABCs, and what you're really looking for is keep the airway open And then remember that you want them to be just like Goldilocks, not too dry, not too wet, but just right. So at this stage, I'd like to leave the floor open for a couple of questions, but I also want to state it's easy for me to talk about this because I'm a neurologist, and neurologists are very deliberate and they take their time about things. My wife used to be a coronary care nurse, and she said by the time a neurologist can decide on a diagnosis and a course of treatment, most patients are going to be dead, buried, and gone to heaven by that stage. So I have to keep my thing in perspective. So thank you very much. Question, white shirt.
I've been reading a journal article from the Journal of Emergency Nursing that was talking about pediatric strokes and shown that a study that was done in 2007 showed that between the ages of 6 months and 10 years, 30% of the kids that had a stroke also had the varicella virus within the last 12 months. Can you speak to that at all?
Sure. If I can repeat the question for the rest of the audience, the question is how often does chickenpox, varicella, contribute to strokes? There are rare reports, and people have actually studied that and found that if you take a population that's affected with varicella, they will have strokes more than the general population. But it's a very, very small percentage. And this gets a little bit technical. The varicella can actually get into the brain, and it can get into the cells lining the blood vessels, and it can cause a temporary, if you will, swelling of these blood vessels, causes a stoppage. And it's known to cause a reversible type of plugging. The doc term is a focal vasculopathy, and chickenpox is known to be associated with this very reversible plug. I would say that for the majority of the individuals that we see who have focal plugs, we ask whether they've had chickenpox, and we don't identify it. So it's out there, and I think the 30% estimate is a very, very skewed number. It's going to be much smaller than that. But if you got kids, vaccinate them. I'm a vaccination proponent. Yes, question? Okay, so the question is, in the young lady with the severe headache and the increased CSF pressure, the only way we could make the diagnosis was by doing MRV. Actually, when she had an initial CT scan that was normal, and then because there was a suspicion that she might, when we see individuals who have increased intracranial pressure, we always think about the possibility, could they have a venous thrombosis? Went back, did an MRI scan on her, picked up the fact that there was a thrombus, and then they went ahead and ordered an MRV, and she literally socked in the entire superior sagittal sinus. And it was amazing. We would have thought that she would have been having more problems, but she was walking around complaining of severe headache. We put her on low molecular weight heparin, and are basically watching till the clot resorbs, and she's still on treatment at this stage. Okay. All righty. Thank you very much.